I'm Dr. Landon Pryor. I'm a board-certified plastic surgeon. I've been in practice here in Rockford, Illinois for about 13 years. I've been in private practice for about going on 9 years. Over the last 8 or 9 years, have built up now a very busy cosmetic practice as well in Rockford. And part of that over the last couple years has been to introduce breast implant illness and explant surgery to what we've been doing here. And it's really been driving itself based on the patient experience and outcomes that we've seen as we've healed hundreds and hundreds of patients now with symptoms related to breast implant illness. We've also started doing some research, our own research in breast implant illness. That's not something that is very heavily studied, and because of that, it has not been well received and supported in the scientific and academic medical community until recently. So as a assistant professor at the University of Illinois, we have with us medical students that have dedicated a fair amount of time to putting together research projects based on information and data that we've collected from our patients, and we're looking to present that information both to you today and ultimately in multiple forms in peer-reviewed types of forums such as meetings and ultimately probably publications, and you'll have a chance to meet those medical students. Let me just say by way of introduction, this is Laura Bowden. So she and I have been working together now for about a year and a half, 2 years as a dedicated what we call breast implant illness patient advocate. So she's exclusively dedicated to helping patients with their journey with breast implant illness from the time of their initial contact to the practice to the completion and resolution of their symptoms and healing from surgery.
So I want to thank you for having us, and thank you for Dr. Pryor for the great introduction. I appreciate that. A little history, a little backstory about me. I was 26 years old and I decided to get breast implants. And within 4 months of having them, I started having symptoms. And I went to every doctor. I was incredibly healthy beforehand, and I went to every doctor, and there were I had no diagnosis. And they just basically said, you're just crazy. There's nothing wrong with you. I knew there was something not right. My gut was telling me, and the only difference that happened in my life was I got breast implants. So I went back to my plastic surgeon and I just said, I'm very ill, and if it's from my breast implants, please tell me. And I kid you not, he did. No. There's no scientific data to this day to show that's why you're sick, but I'll take them out in the office if that makes you feel better. So that became my journey, and I was there for 2 weeks and had my implants taken out after a host of terrible symptoms, chronic fatigue, debilitating fatigue, memory loss, dry eyes, muscle twitching, inflammation, IBS issues, everything that we have on the symptom sheet, you'll see as we move forward. And I had my implants removed properly, and only by the grace of God. We didn't even know what an end block was back then. The fact that my implants were taken out with an end block is absolutely a God thing. Within 24 hours, all my symptoms went away. And my neurologist, whose care I was under, I said, how can I feel so much better? And he said, you're one of the lucky ones. You were young, they were not ruptured, and I was that ill. And you were healthy, and it's like taking the logs off the fire. Once you remove your implants, your immune system settled down. And with that, I had made friends in those 3 floors of women, and I needed to go home then, live in Illinois. And I went back to every single room of these women that had rupture after rupture. Some were living in their cars because they lost everything. Many of them were divorced because they got their implants for their husbands, and their husbands left them when they were sick. So these relationships that I developed in 2 weeks, and I went to everyone's room. I was one of the youngest ones there, and I promised them that I would come home and I would be their voice. So I kept that promise. Oh, this is going to be tough. I started talking, and a woman got a hold of me and said, we are doing a documentary in Illinois with 20 sick women or women that got better. Would you like to be part of it? I said, absolutely. And we reached out to every single plastic surgeon in Illinois to come and speak to these women, enter the lion's den, and not one showed up but Dr. Pryor.
Great, quite a story.
Did you know all that?
Yeah, I mean, I knew it. I've heard it a couple times, but yeah. It is pretty amazing when you put it all together.
It is amazing.
I'm on for meat and potatoes?
You are.
Okay.
You're the main speaker.
So what is breast implant illness? it's really a constellation of symptoms that we've come to recognize related to patients' breast implants. And like I've said, we really don't know how commonly this is occurring. That's really the $1,000,000 question. Is it 50% of patients? Is it 5% of patients? Really anybody's a potential candidate that has breast implants and has symptoms possibly related to their implants. The current hypothesis as it relates to the development of breast implant illness, in my opinion, is related to genetic predisposition. There's a number of theories that potentially are correlated with why somebody with breast implants has a reaction to them while others don't. There's a gene mutation called MTHFR, which has been implicated. And in just like, some patients, if you do surgery on them, they're going to get a keloid, and others are going to heal with a perfectly fine scar. Our bodies all respond differently to different types of trauma. And for whatever reason, in some patients that have potentially a genetic predisposition, they develop what I think is an inflammatory response. Anytime you put a foreign body in a human being, the body is going to generate an inflammatory response. Anytime you stub your toe or make an incision, there's going to be inflammation. But typically there's kind of an on and an off switch as it relates to inflammation after trauma. And similar to the keloid analogy that I just made, I think that applies to patients with breast implant illness. So breast implants are put in, the body creates inflammation as part of the healing process to protect itself. Some patients, that on switch stays on. It creates additional inflammation systemically throughout the body. And in my opinion, that translates into this diverse spectrum of symptoms that we see, which vary from individual to individual, but they're all common among the breast implant illness patients. And they're very nonspecific and they're hard to diagnose. So symptoms like this oftentimes cannot be well categorized into a definitive medical diagnosis. Usually these patients, by the time they're coming to see us, have been to multiple physicians, have had lots of diagnostic tests and workups done with very little, if any, conclusive information as to what their medical diagnosis is. Many times patients are told, kind of get used to it, you're getting old. Those are all kind of common responses that patients tell me they hear from their medical professionals that they see. Many of them have even brought up the possibility that it's related to their implants, and typically that's discredited pretty quickly. And so, unfortunately, a lot of times patients are living with these implants, potentially causing the symptoms for years, if not decades. And it's only really recently, I'd say in the last 5 years, that the breast implant illness community has really kind of become self-aware. Fortunately, now in this day and age, patients are their own best advocates, and they get on the internet and start Googling around, and before they know it, they go down this rabbit hole of breast implant illness and typically find providers and information about breast implant illness that ultimately leads them on a journey. These patients have all, prospective patients, these former patients have banded together and formed these big coalitions and social media groups that allow them to communicate and share their experiences and their stories in a way that previously they were not able to. And I think for many of them, it's like, wow, there's something going on here that I had no idea potentially is related to my breast implants. And so sometimes to see me or somebody else that can help them. So that's kind of how they end up in my office. And then, we start a conversation about expectations related to what breast implant illness is, what it's not, potentially what we can do to help them feel better, setting realistic expectations, letting them know that, this is an elective surgery, just like any other elective surgery that we do. They fill out a symptom questionnaire. It's got about 50 different symptoms on it, broken down into different categories. Most of the time, the patients check almost all of the different symptoms. And I told them, it would be great if we can help you, feel better by doing this explant surgery. But I can't make promises about what symptoms are going to get better and which ones are not, and if they're going to get better at all. We can just give them hope that, based on our experience and the experience of now hundreds of thousands of women on the internet that have resolution or improvement of their symptoms after surgery, that there's hope. They don't have to live in despair, and if they're sufficiently motivated to take action and do something to try to help themselves feel better. Most of them have already tried everything traditionally to feel better, both in healthcare and in other modalities, and without any success. So usually the patients, by the time they get here, are pretty desperate for answers and solutions, and so we offer that to them as a potential way to help them feel better, understanding the risks of the surgery and the potential downsides as it relates to the appearance of the breasts and changes that inevitably will occur after surgery, understanding that patients got implants for a specific reason as it relates to the appearance of the breast, and we're going to be undoing that, so to speak, and doing our best to preserve the form as much as we can in the process.
In one support group, there's 158,000 sick women in Nicole's group. 158,000 sick women, and there's 200 support groups. So literally, by the time the patients get to us, not only do they want the surgery yesterday, they've done better research than the FBI. So by the time that they know exactly, they know about an en bloc, they know about Dr. Pryor, they know to go to a brilliant surgeon that knows how to do a proper removal. So this room, a lot happens right here. This is where they realize they can get their life back.
Hi, I'm here with DAYNE HESTER. He's a third-year medical student at University of Illinois in Rockford. He actually just got 2 awards, right, for scholarship recipient for outstanding academic excellence. And he's been working with the Pryor Health team, the Breast Implant Illness team, on putting together some research related to breast implant illness for probably about the last 9 months, 12 months, something like that. And obviously he showed an interest. I think you actually rotated on the service, and then from there he showed an interest in learning more about breast implant illness and hopefully contributing to the development of additional scientific data and protocols related to breast implant illness. So that's also something that we're interested in doing, and there is a paucity of data available. So DAYNE is one of 4 medical students that we have currently at Pryor Health working with our breast implant illness team on better defining a couple different areas of breast implant illness. Everybody's got a little bit of a different niche within breast implant illness. His in particular is focusing on capsular contracture. So what he's performing now is called a retrospective chart review, which basically means we're trying to get information from looking at the charts of patients to determine if there were some particular risk factors that the patients had that contributed to the development of symptoms related to breast implant illness. And so one of the theories or hypothesis related to breast implant illness is that there's an inflammatory underlying cause in some patients for whatever reason that contributes to these symptoms, that develop these systemic symptoms. And it's also very similar to capsular contracture, and there's a little bit more known about capsular contracture than breast implant illness. So we hypothesize that there's going to be a correlation between capsular contracture and breast implant illness. Ultimately, it's kind of a different presentation of the same underlying etiology or pathogenesis, meaning that there's something that's causing this inflammatory reaction, which is kind of outside the norm for what we typically see as an immunologic response to breast implants, that either manifest as capsular contracture or kind of go on to a spectrum of further inflammation culminating in breast implant illness. And potentially, this is kind of outside the scope of today's presentation, that might even progress further to different types of cancers that are now being found inside the actual cancer, which all have a common underlying etiology of the inflammatory process that's not being turned off like it should be after kind of a typical response to injury. Just like a keloid is an exaggerated inflammatory response to an injury, whereas most people develop a scar and it goes on and heals and that process turns off. In some patients, because of genetic predisposition, they go on to develop hypertrophic or keloid scars. And so my hypothesis is very similar for some reasons that we can talk about again outside the scope of this presentation, but patients are genetically susceptible to having this prolonged inflammatory response to breast implants that ultimately culminate in either capsular contracture or even potentially more severe breast implant illness, symptoms related to breast implant illness, and potentially kind of on the other end of the spectrum, a breast implant associated type of cancer like ALCL or squamous cell carcinoma or other lymphomas that we're now discovering have been found within the actual capsule of breast implants. So all of that being said, our hypothesis was that the capsular contracture would potentially predispose patients to developing breast implant illness in a subset of patients because they are essentially a different side of the same coin, resulting from the same inflammatory process in some patients and not others. And that isn't fully known as to why that happens, but the most prevalent theory regarding capsular contracture is that it's related to a quote-unquote biofilm that forms around the implants, which basically means a bacterial contamination. The body's surveillance system works really well when there isn't any foreign material present because it can identify foreign invaders, bacteria, virus, and other pathogens and clear them. But with the actual presence of a shell, inorganic shell, like in an implant, any kind of implant, that predisposes the body's surveillance system to potentially not be able to eradicate or clear the pathogen because it's not in a vascularized setting. So that contamination on the implant or that biofilm could potentially be what's contributing to the development of this ongoing inflammatory cycle that ultimately ends up in capsular contracture or symptoms of breast implant illness. And so we have not finalized the data collection yet. We have to look further into the specifics of each patient chart to better identify where there is a correlation and then do the statistics to determine how much of a correlation there is and try to identify if this is something scientifically that we can prove. And so once we have that finalized, he'll be putting together an abstract for publication and ultimately a publication in a scientific journal. Hopefully that will help contribute to have additional information and awareness present in the medical community to, again, just continue to identify and help patients that are suffering from symptoms of breast implant illness. Thoughts?
No, I think you hit the nail right on the head with all of that. Main thing is that it's a deranged immunological response to a foreign body that continues on, that looks like a spectrum of a disorder that we are trying to identify and provide some information for these patients so that and to the scientific community so that we can show true data on this topic so that we can provide information to everyone, the scientific community, and to those who are suffering from breast implant illness.
Yeah, and I think one of the limitations, obviously, of this study and in the breast implant illness community is what's called the power of the study, meaning we just don't have a lot of numbers. So we would have to put together a number of different studies to have sufficient data to make it statistically significant. But we're going to use the information that we have and the patients we have available to try to put together something that's as scientifically validated as possible.
So the most interesting thing I learned was actually coming in and seeing a patient with breast implant illness and putting a story of a patient with the actual study that motivates me so much more to put this study together and do this research for these patients that are suffering from this disease. So that's the one thing that I learned most, that this is a derangement in immunology, that this goes back to, like Dr. Pryor said, our body working kind of against itself, and this could be a reason why several patients with breast implants end up having autoimmune disorders that could be cured from treating this underlying problem. So there are several patients out there that are probably living with lupus and other immunological problems that are as a result of their breast implants, and I think that these people deserve to have answers as well as the scientific community and clinicians to make decisions and inform patients in their offices the risks and benefits of undergoing breast augmentation. So that those are all the things that have been really important lessons that I've learned during this study.
That's great. Thank you. Yeah, obviously, I agree with everything you said. There's definitely the need for informed consent process in every patient surgery. And you rotated on the service, so you saw these patients firsthand.
Yeah.
And so I'm just curious, what was your initial impression when you started to work with me, I believe, and you saw patients in the recovery period that said how much better they feel and just how it's changed their lives? What was your initial thinking or impression?
Yeah, so initially, I was a bit of a skeptic. I would say that I didn't think that we would see such a profound change after the explantation to the complete resolution of symptoms. Not every patient has a complete resolution of symptoms, but this one in particular did, and it was actually quite beautiful getting to see that patient after explantation with fat grafting to the breast. Actually was happier with her breast after fat grafting and happier with the way she felt post-explant. So getting to see and listen to that story was an extraordinary experience.
Awesome. Well, we expect great things from the young Dr. DAYNE.
Thank you.
As he continues to finish up his medical education and hopefully get into a surgical residency. I'm advocating for plastic surgery, and I think that's the direction you're headed.
Yeah.
So we look forward to great things from you in the future. So
Thank you.
Appreciate it. So we're here with Shahina. She's also a third-year medical student at University of Illinois in Rockford, and she's doing a really interesting study as part of a grant through underserved patient populations here at University of Illinois in Rockford, and specifically looking at microorganisms and the pathogenesis of breast implant illness. Very similar to DAYNE, the other medical student's publication related to biofilm. Kind of if you look at the progression of breast implant illness, the hypothesis is it starts with contamination or microorganism contamination of the implant and capsule that potentially progresses to development of inflammation, which we measure with inflammatory markers, and ultimately culminating in potentially capsular contracture, which has been implicated in the development of breast implant illness, with a common cause of biofilm ultimately related potentially to contamination of the implant with pathogens.
Hi, my name is Shahina Gatawala. I'm an M3 at UIC College of Medicine, Rockford campus. And my project is the microorganisms and the pathogenesis of BII. So after conducting a literature review, I found scant evidence of research papers describing organisms such as Propionobacterium acnes and extreme amounts of staph epidermis in explanted breast implants. However, there isn't significant evidence that points to these specific organisms being the exact cause of breast implant illness symptoms. So the objective of my project is to have the breast implants that are removed from the patients be swabbed and then analyzed for microorganisms in a local lab in Rockford. After that, I want to be able to take the microorganisms that we find, if we find any, and extrapolate on the symptoms, find a correlation between the microorganisms we find and the plethora of symptoms that consist of breast implant illness. So that is the overarching goal of my project. I was interested in this project because I remember Dr. Pryor mentioning that there have been negative labs from the patients before, and so I want to see if there is a potential to have a larger subset of patients to test this theory on. So let's see what we find, and hopefully it's enough evidence to make breast implant illness be an accepted diagnosis in the medical community. Shadowing Dr. Pryor and seeing the capsules of those breast implants being removed, it was just shocking that that's even within the body. So after hearing that Dr. Pryor didn't really have any positive lab findings from these patients that he removed the breast implants from, I really felt that I really wanted to explore this. Maybe from a few patients there's nothing, but if we have a larger subset of patients, maybe we'll be able to find something. Because in these scant papers, there is evidence of certain normal bacteria being there's such a large quantity of those bacteria that there has to be some type of connection that we can make and potentially contribute towards breast implant illness being an actual diagnosis accepted by the medical community. I mean, I feel like there has to be a cause and we just don't know it yet.
All right, so now today we're here with Danielle. She's a second-year medical student at University of Illinois in Rockford, and she's going to present her work on a research project that she's been diligently working on related to breast implant illness. Actually has funding through the university, so with that, I'll let her take it away.
Hello everyone, thank you for having me. To start, I'd like to touch on a little bit of background about my study. So CD30 is a receptor that's found on both T cells and T regulatory cells. Its function particularly is involved in the two-signal model in order to start inflammatory processes and anti-inflammatory processes within the body. And it does this by interacting with its co-receptor CD30L that is found on dendritic cells. And so for our study particularly, we are interested in CD30 and CD30L interaction corresponding to its attachment to T regulatory cells. Looking at the literature, it says that CD30 and CD30L interaction plays a role particularly in transplantation tolerance and graft versus host disease. In fact, in a specific study, as you can see here in 2007, researchers inhibited the interaction of CD30 with CD30L, and then there was an inability to control the ongoing inflammatory reaction within the body. So what this is basically telling us is that CD30 and CD30L play a very important role in suppressing inflammation within the body, and it is very important in regulating and preventing autoimmunity that can further occur. But as Dr. Pryor mentioned, we are specifically looking at serum CD30 in the body. And so serum CD30 is the extramembranous region of the CD30 receptor once it gets cleaved by a metalloprotease. And when this occurs, it basically circulates in the tissue and can be released into the bloodstream where it can be measured. The problem with this, however, is serum CD30 can still attach to its CD30L receptor. And when it does this, it blocks further interaction with the CD30 receptors that are still attached to the T regulatory cells, which means that anti-inflammatory processes cannot occur. So researchers have been exploring this interaction and this blocking and in autoimmune diseases. And what they found is that in Sjogren's, rheumatoid arthritis, lupus, Wegener's granulomatosis, Graves' disease, and Hashimoto's disease, there's a significant increase in serum CD30 during these disease processes. But this has yet to be studied in breast implant illness. And so what we would like to do in our study is analyze serum CD30 levels both before and after explantation surgery in our breast implant illness patients, with a hypothesis that serum CD30 levels will be significantly increased in patients prior to their explantation surgery, and then we will see a significant decrease after their explantation surgery. And if this hypothesis holds true, implications for this study will allow us to better learn the etiology of breast implant illness and the pathways that are occurring in the body. It'll also allow us to better understand breast implant illness's relationship to other autoimmune diseases and potentially lead us to a diagnostic marker in breast implant illness, which would be very helpful for future patients. The overall impact that this disease truly has on its patients, and that it's still a diagnosis of exclusion, which basically means that we don't have specific criteria to diagnose breast implant illness, and there isn't a diagnostic marker. But that, research is still ongoing, and so I think that when you learn about the impact that it has on its patients, it's really kind of like a push to get you involved and get you to ask questions and get you to look into the illness more. Currently, our study is still ongoing. If you have any questions or comments, feel free to contact me at the email address listed here. Thank you.
Well, now I'm here with Claire. She's a third-year medical student here at University of Illinois in Rockford. She's actually performing 2 studies with us, overachiever, of course. She's part of the James Scholar program, so obviously very bright. And her 2 studies focus on the influences of MTHFR, which is a genetic mutation, on the development of breast implant illness, as well as measuring inflammatory markers before and after surgery to better demonstrate the scientific basis of breast implant illness. So we're definitely excited that she has decided to work with us on BII and look forward to great things from her.
Hi, my name is Claire ROESLER. I'm a third-year medical student at University of Illinois. So the reason I came to medical school was to be a patient advocate. When I was much younger, I had a really bad back injury, and I bounced from doctor to doctor to find out what was wrong with me, and nobody could, and they told me the pain was in my head, and I should learn to live with it or to see a psychiatrist because there was nothing wrong with me. But finally I found a doctor who listened, and because of it, I no longer have pain. And that's why I really resonated with BII and why I really want to study it and, help empower women to know what's going on with their bodies. There's so many women that are suffering and nobody listens to them. And I don't know what it's like to have BII, but I know what it's like to not have your doctors listen to you. I have 2 projects that are ongoing for BII. The first one is looking at the relationship between MTHFR and the development of BII. So MTHFR stands for the methylene tetrahydrofolate reductase protein, encoded by the MTHFR gene, and it is involved in the inflammatory process in the body. So given that its involvement in the inflammatory process, it's been hypothesized that certain women that have mutations in this gene will go to develop BII. So the purpose of this project is to determine if a relationship exists between mutations in the MTHFR gene and the development of BII. The next study is to assess the surgical removal of breast implants as a potential management option for breast implant illness. So there's currently no standard management for BII. Some people argue that removal of implants, termed explantation, resolves symptoms, but other studies have found that there's no change in symptoms. So this study will be assessing inflammatory markers before implants are removed and also afterward to see if there's any change in inflammatory levels in the body.
Over the last 2 years, Laura and I have been working very closely together, and we just continue to see improvements in patient symptoms. There still is not really much as far as what we can do from a diagnostic standpoint, even like compared to 30 years ago. It's still very much a clinical diagnosis. We objectify it as much as we can. We have patients fill out symptom sheets and do the same informed consent process about the expectations of symptoms potentially not improving after surgery. But we are very sophisticated with responding to the patient's needs, understanding the kind of limitations of the surgery, and meeting their expectations for potentially getting pathology done if there's any indication that there should be a histopathologic diagnosis. We're very vigilant about photo documentation of the surgery and letting the patients kind of see with their own 2 eyes what's happening in surgery, and ensuring that all of the capsular tissue has been removed. Recently, even since having started doing the explant surgery, initially the FDA came out with a warning that ultimately culminated in a black box labeling for implants because they were finding this ALCL, anaplastic large cell lymphoma, which is a rare type of lymphoma that's found typically around textured breast implants. So this is all kind of new within the last couple of years, and so there's been a lot of interest from the scientific community about ALCL, and then more recently there were some additional findings of other types of cancers, breast implant associated squamous cell carcinoma and other lymphomas in the capsules of patients that had their implants removed. So because of that, that's brought a lot of awareness, I think, in the scientific community and in the general population to kind of what's going on really with breast implants, and why are we finding these rare cancers, and is there more we could be doing or should be doing. We just want to make sure that patients are going through an appropriate informed consent process, because implants are still on the market. There's lots of surgeons that still do breast augmentation. We don't know the incidence of breast implant illness. I no longer put in implants. I stopped that around the time that Laura came on, just because I wasn't comfortable taking them out and putting them in. Really because I saw the improvement in the patients doing the explants, and I just didn't want to be a surgeon that was potentially doing something to my patients that wasn't in their best interest. And I just couldn't do that. So I was like, okay, like there's something real going on here. So I just can't justify continuing to do breast augmentation. So as far as, quote unquote emerging trends in breast implant illness, I think, our clinical outcomes continue to speak for themselves. We have patients, I do a lot of explants. I think Laura said, 800 or something like that since she's been here. And so, almost universally patients get better after surgery. I mean, the proof is in the pudding there. So like Laura said, you can't make this shit up. The breast implant illness clinical outcomes have continued to fuel what we're doing as far as growing this, center of excellence, because, while I'm kind of leading up this initiative, I'm only one surgeon, I'm only two hands, I can only help, so many patients. So really the only way for me to, be able to help more people is to kind of scale what I'm doing from a surgical standpoint, to be able to expand our resources and potentially bring more knowledge, awareness, and surgical outcomes to more patients across the country and across the world. So, here at least at Pryor Health, we're trying to, like I said, continue to provide resources to as many patients as possible. And so the best way that I know that we can do that is not through just doing more surgeries, but is through educating the next generation of surgeons. And so we're kind of in a unique position because we're well capitalized. We've got the ability to go out and essentially work with or acquire other practices that are also focusing on breast implant illness, because there's only a handful of surgeons in the country that are really, kind of sophisticated as far as what the patients would perceive as kind of the best in class explant types of surgeons. So our plan is to partner with them and their practices and kind of put together this best in class center of excellence that's going to include obviously best clinical outcomes, continue to work with medical students both here and anywhere else, and probably kind of beyond that once we get into more academic institutions, doing more clinical and basic science research to help better define and hopefully treat down the road the cause of breast implant illness. So we're in the process of starting the first only in the U.S. explant fellowship. We actually have a fellow with us now that will be our inaugural fellow that's kind of learning the way that we do breast implant surgery and manage those types of patients, so that when he goes out into practice, in a year from now, he can be, continuing to do that work and help patients in his neck of the woods, his geography, and coupling that with kind of our own core philosophy of not only helping patients look better, but feel better. Because of that, we're going to be continuing to add additional service lines that will help patients not only go through the surgical process, but the detoxing is very important. So we'll make sure that we've got appropriate resources that will help them both before and after surgery to maximize their recovery. And that also includes mental health resources. We're partnering with Amanda Savage, who is a great counselor that works with our patients throughout their entire experience here to make sure that they're being taken care of, not only body but mind and spirit as well, so that they can kind of get back to living their best life and improve their quality of life the best that we can.
So when we talked about the detox, we
Yeah.
do have Mandy Kroll also that we refer our patients to, that does study on helps women detox what works for their body. So the nice thing about it is all different pieces of the puzzle to make this all work. It's just now getting explanted. It's the mental, like Dr. Pryor said, it's the mental support to be prepared for this type of surgery. We got them for a reason.
We really think this is kind of the marriage that's going to allow surgeons to be successful. We want to make sure that we can bring awareness to the importance of not only having advocates like Laura work with the patients, but having outside resources, like we said, that can help them with kind of the mental health journey as they go through the explantation, surgery, and recovery. Hopefully this has been informative and, just kind of giving you an overview of what's going on in the breast implant illness community. It is starting to get additional traction and being talked about at the scientific level in academic circles and at meetings and in society. So we do see this continuing to improve, and we think we're heading in the right direction. So it's still very much kind of a grassroots approach and making sure that we're just taking care of the patients one at a time and doing what we can to continue to bring awareness to this, really kind of global problem right now. So thank you for your attention.
Thank you.